Audio recording for this meeting has begun.
Everybody hear me? No feedback. So we're going to start this off right on time. I just want to introduce everybody and thank those who are logging in right now. I am Dr. Brian Jacob from New York City, where we survived not getting a tornado, so that's a good thing. And I want to thank SAGES, specifically the Resident Education Committee, Dr. Catan and Dr. Brett Matthews, for the invitation to host this event, and then for really a truly very special, gifted, and experienced faculty for agreeing to do this with me. I couldn't do it without them. Specifically, tonight's webinar is called Patient-Centered Outcomes in Inguinal Hernia Repair, Recurrence, Pain, Quality of Life. And really at the forefront of this, as we enter this next decade of the century, is Dr. Todd Heniford, who is the Chief of the Division of GI and Minimally Invasive Surgery from East Carolinas. Todd, thank you for joining us today. From UCLA, also at the forefront of figuring out how to cure postoperative pain. and who's become a very good friend of mine and also someone I refer patients to, Dr. David Chen from UCLA. Thank you for joining us. And who will hopefully be able to log on later, but if not, because he is arriving in Beirut, Lebanon, is Dr. George Ferzli, who's professor of surgery at the State University of New York here in downstate. So thank you very much. We really couldn't do a show like this without your type of experience to contribute. For those that are logged on, just a little bit of homework. You can communicate with us as a group or specifically to any one of the presenters by typing in the bottom of your screen in the blank box after clicking on whether you want to talk to everyone or the hosts or the presenters. And we encourage this to be interactive. So you can ask questions during it. We may ask questions of you to sort of log in. It becomes a better webinar when you respond as opposed to staying silent, so we encourage that as well. And so that's really it. Hopefully everyone can hear me well. If you're there, don't be shy, log on and just say hello. You're sitting there watching us. And again, welcome to tonight's webinar. And with that, I'm going to turn the microphone over to Dr. Heniford from East Carolinas.
Brian, thank you very much. It's a real pleasure to have the opportunity to present, and I certainly appreciate SAGES allowing me to participate in this and very important topic, and also to serve on this panel. Of course, I was assigned the topic, Outcomes Are Paramount, Predicting Chronic Pain After Inguinal Hernia Repair. I essentially wanted to take this and express the importance of it. And we'll give a fair amount of data with this, but also get to the nitty-gritty of hernia repair is the most common operation performed in the world. And for decades, the measure of surgical success has almost solely been considered the lack of hernia recurrence. It is traditional thinking. Indeed, the underlying tone in most meetings around the world is that this statistic is the holy grail. It qualifies a surgeon's level of success, competency, and surgical prowess. Undeniably, if one adds a surgeon's speed in performing the operation and the incidence of infection to the spreadsheet, then we've reached the ultimate time-honored, comprehensive measure of hernia surgical success outcomes. Today, an enhanced understanding of anatomy, better defined surgical techniques, and the availability of meshes have substantially decreased the incidence of surgical failure. While the burden of recurrence has not left our conscience, the advances in herniology and education that have been stimulated and propagated by many surgeons around the world have impacted this specialty in a remarkable and positive manner. These technical, educational, and scientific advances, additional success has increased decidedly. With the growth in science, skill, interest, and confidence in this field, in hernia, it's become its own specialty. However, modern medicine has consistently privileged the objective features of surgery over its subjective and pragmatic, while simply measuring recurrence or OR time, infection, which are important but basic concepts. This approach unavoidably renders an incomplete by not including the perspective of our patients, whose daily experiences are shaped by their quality of life. In other words, our customary approach and appraisals favors an outsider's perspective rather than the insider's. This separates surgeons from patients. It also forms a disconnect between surgeons and their role as patient advocates. Given our recent successes in conventional measures, I strongly believe that it's time for the next phase in hernia surgery. I believe that the new paradigm in hernia surgery is looking at a patient's quality of life. Thus, recurrence per se is no longer perceived as the only or grandest endpoint. The goal should be to improve, restore, or preserve quality of life. This concept, of course, is not new. It's been spoken of by the Greeks and the Romans. Jeremy Bentham, a leading theorist of his time, developed the greatest happiness principle, which concludes that subjective well-being is considered to be the ultimate yardstick to be used to assess the current state and development of a society. Chronic discomfort after inguinal hernia surgery is a well-documented problem. It's the most commonly recognized complication for the most commonly performed operation in the world. It is reported to occur as frequently as 8 to 40% of all. However, in more than 15,000 articles in the surgical literature discussing inguinal hernia repair, less than 40 focus on quality of life. Lack of attention that exists in the literature also exists in surgeons' offices. Surgeons focus preoperative discussions on conventional complications and recurrence rates, most often fail to address postoperative quality of life outcomes in the process of informed consent. A study of inguinal hernia patients demonstrated that chronic pain as a possible complication is discussed during surgical consent 14% regardless of the level of training of the consenting surgeon. This lack of appropriate communication leads to failure of the patient's expectation and dissatisfaction with the operative results, the surgeon, and even the system. In the same breath, I recognize it's very difficult to convey to patients they have a chance of chronic discomfort of 8 to 40%. How do you effectively do that? These questions and uncertainty, this fact will provoke, the questions and uncertainty that this fact provoke are difficult to overcome as a consenting surgeon. Given this consideration, there's clear and present need to be able to estimate the probability of chronic pain during the preoperative visit and allow us to identify those patients at significant risk so that they may be thoroughly The incidence of chronic discomfort is now being picked up by our patients and the press. Chronic pain after inguinal hernia repair is the most common reason for malpractice lawsuits following hernia repair in the UK. We did a study through CMC here, all the malpractice case law surrounding 35% of those cases were due to pain after. The press has also picked up this growing topic. As demonstrated by this Wall Street Journal article, it became popular blogged articles of the week that it came out in February of this year, and a second article was actually run later the next week. Unlike the simple yes and no answers for recurrence, quality of life is a broad and complex matrix. Traditional quality of life after surgery, like other medical conditions, has been tested using generic indices such as the SF-36, although it's well studied, is a generic instrument and has not been found to be a sensitive tool for patients. 6 years ago, we developed and extensively tested something we call the Caroline's Comfort Scale. Since that time, the application of the CCS has grown dramatically and currently has been utilized throughout the United States and in 42 countries worldwide and has been translated into 32 languages. Also being used by the French and British government as a measure of quality of surgery and hernia repair. A little question that we do, what we measure affects what we do. What we've needed is unbiased, high-quality surgical and quality-of-life outcomes data associated with hernia repair and lots of it. With this consideration, the International Hernia Mesh Registry was begun in 2007. A global board of surgeons gave oversight, and surgeons and surgical scientists from Australia have contributed over 4,000 patients, and these come from 37 centers in 10 countries. There are several factors that make this data remarkable. First, it's a 100% prospective information that does not come from the microcosm of Charlotte, North Carolina, or even the United States. Specialized surgeons and their patients on 3 continents. Of course, the surgical data was assimilated in the hospital, but the patient specifics have been collected directly from the patients themselves, away from the hospitals and away from the clinics, either online or by mail, by a third party in a totally anonymous fashion. Patients have been guaranteed anonymity. There's no question that if I walk into a patient's room and give them a quality of life scoring system and they know that I'm coming back to pick it up, it would affect what they put down there. Numerous past studies have proven this to be the most effective way to eliminate researcher and observer bias. Surgeons in this study had no control over what their patients might say or any information released. This has been a remarkable, impartial, and unprejudiced dive into the evaluation of best surgical practice applications and their corresponding quality of life outcomes. The unique nature of the IHMR lends itself to complex mathematical analysis. There are nearly 2,500 inguinal hernia patients with 77% one-year follow-up. That would be more than 3.5 million data points to evaluate. And data mining is not only daunting, it's overwhelming. It's kind of like quantum physics, interpreting how all these individual variables impact each other and then influence the results. There are many important factors that were distilled in the refining process of this information, especially when we examine the long-term outcomes. First, we found that in experienced hands, whether you perform the operation open or laparoscopic, recurrence rates and quality of life were the same. I find this very interesting, and it just supports that surgeons should do what surgeons do. Next, European and American surgeons' outcomes when compared head-to-head were statistically identical. Analysis of this data, whether open, laparoscopic, American, or European, were a lot closer than we thought. In this data set, we knew we could find the factors that led to postoperative pain. We used statistical analysis, including categorical variables, continuous variables, identification of potential independent variables, and others. What we found is that the independent variables, which lead to a significant chance of chronic discomfort, where one would be preoperative symptom severity. The more symptomatic a patient is prior to surgery, the more likely they are to have symptoms after surgery. Patients with recurrent hernias. Patients who have recurrent hernias are much more likely to have discomfort after surgery. Patients with bilateral hernias. Again, bilateral repair yields a greater chance of postoperative discomfort. Women certainly had a greater incidence of discomfort after inguinal hernia. Also, age. Younger patients did not do as well as older patients. Taking all of this data, essentially what we did was took 1,700 patients, we took 80% of their data, and made a formula essentially to predict those patients who would have chronic discomfort. We then took the next 20% of that data and then tested it. And we call this equation the Carolinas equation for the quality of life. And I have to give Amanda Walters and Amy Lincourt, Christian Dacey, Igor Belinsky, Victor Serling, and Paul Calavita a great deal of credit. People that work in our division, our department, fellows who have actually moved on now. But this is, if you want to see the equation, if you want to write it down, here it comes. This is what the equation looks like. Very, very complex. Wanted to make sure it was right, of course, and the sensitivity and specificity were terrific. And using a model such as this equation is so complex, it truly is impractical for use by physicians in the lay public. So therefore, what we did was we developed an app. Desktop, handheld tablet computers, and smartphones. It's the first predictive app for medical or surgical outcomes. Questions about themselves, their hernia, and their current quality of life status as it relates to their hernia, and a percentage chance of having discomfort 1 year after surgery. Our ultimate goal with Sequel is to use a mobile app technology to provide surgeons and patients with a powerful educational tool that can predict individual quality of life outcomes after inguinal hernia surgery. I feel this sets a stage for what we should strive for with every operation or treatment plan, an objective tool to predict personal quality of life outcomes from a proposed operation or therapy. We can lead. This should be the tipping point where life quality and performance becomes the standard for all surgical and medical therapies, for treatment of heart failure, for chemotherapy, for pancreatectomy, for all treatments around which we have enough data to soundly predict quality of life after that therapy. These quality of life projections should enter into the consent process. Patients should have the opportunity to weigh them in their decision-making. How else might we use this predictive information to impact what we do? These statistics may allow us to perform patient-directed instead of hernia-directed care. In patients with a significant risk of chronic pain following herniorrhaphy, perhaps it would be more prudent to perform an IRB-approved randomized prospective study to include injection therapy, triple neurectomy, other procedures at the original time of operation. And I'd certainly love to hear David and Brian's ideas about this. But of course, it comes to this. It comes to taking care of our patients. We need to provide appropriate consent so that patients know what they're getting themselves into. Of course, as Martin Luther King stated, it's the quality of one's life, not its longevity. That's what's important. They're the past presidents of the American Hernia Society, and these gentlemen and I have had long discussions about repair of hernia. All of them agree they would rather have a recurrent hernia and a good quality of life than a repaired hernia and a poor quality of life. When surgeons don't fully prepare them patients for surgery, it reminds me an awful lot of deal with simulation and how they compare us to airline pilots. The big difference between a pilot and us is that the pilot is on the plane. Investments are poles apart. Types of things will make me think about my children, and I'll stop here, Brian, and take any questions.
Thank you very much, Todd. That was a terrific talk. And again, welcome to anybody else who has logged on over the last 15 minutes or so. Just so you know, you can type in questions in the bottom left-hand corner of your screen. If you wish to see a presentation full screen, there's a full screen click button on the top, so don't be afraid to use that. We need to hear from you. And Todd just gave a wonderful talk on predicting postoperative pain. And Dr. Heniford, what we don't realize is you're inspiring a lot of younger surgeons out there, myself included, to really reconsider what we used to think of as the most important outcome variable as we shift over to quality of life. And when we interview patients now, at least what I do, is I'm paying a lot more attention to the questions I'm asking them. And you mentioned that preoperative symptom severity is probably one of the more significant independent variables. How do we extract that information from the average patient? What's the best way to do that? And then the second question is, with your new app, which I'm starting to implement into my practice, how can patients use the information that they're getting from that to help choose the right surgery and the right surgeon in the right place? And how can surgeons use this information to decrease those incidences, which we know are higher than are reported?
Well, those are some great questions, Brian. And the way we use the app, for the most part, is just to make sure that patients understand there is a chance of chronic postoperative discomfort after inguinal hernia repair. A patient recently who came to see me with chronic pain, they said their surgeon said they had never even seen this before or heard of it before. I mean, that's what we really and truly have to stop.
Right.
It's all about appropriate consent for the patient, no question about that. One of the things that we can use the app for, and we'll be moving to and are moving to in our institution, is patients who are at a very high risk of chronic discomfort. Those patients, again, perhaps we need to do patient-directed therapy instead of hernia-directed therapy. And I certainly, with David's experience, certainly like to hear what he has to say about that. For the patients themselves, the app is not going to help them choose a surgeon. What it can do is arm them to ask the surgeon the correct questions, the right questions, and prepare themselves if they want to move forward with an operation. I've had surgeons will say, well, Todd, the patient will get this app and not want to have hernia surgery, especially if they're asymptomatic. Well, actually, the patients who are asymptomatic, like by the direction of the question you mentioned a few minutes ago, the patients who are asymptomatic are much more likely to be asymptomatic after having their hernia repaired. The other good news about this is the patients who come in symptomatic, 90% of them, more than 90% of them, are rendered symptom-free. Not purely as an educational tool, consent tool, just so patients come in and they don't get jaded by the system, the surgeon, all.
I, for one, have started to use it to educate myself on some of these incidences based on that great formula. As far as documenting pre-op symptom severity, yep, is there any advice you can give on how to best do that?
Well, I'll tell you, we do it using the Caroline's Comfort Score because we track all of our patients, and we've kind of developed a system. We have that network. If you're not going to track what your actual patient's severity, symptom severity, then essentially what it needs to do is to alert you. The patients who come in with debilitating pain from an inguinal hernia repair, really need to warn them, or even patients who have significant discomfort with inguinal hernia repair, you need to warn them, I may fix your hernia, but you may still have your pain. Many of the patients that I see who have chronic groin pain after inguinal hernia repair, you actually ask them, is this the same pain you had prior to your hernia repair? The answer is yes. They don't have a hernia recurrence, but they have the same pain. Indeed, it may be true you have a hernia, true you have.
I agree completely, and I think it's also important, especially in the more athletic people, to distinguish whether or not the pain came in the onset and really try to dive into the pain that they're complaining about when they come in. And this is in the group that has not had a hernia repair before. So those that come in who've said, all of a sudden over this weekend I developed this new pain. I tore something. I must have a new hernia. Those are the patients that I think we need to better educate. David. Dr. Chen, are you there?
I think they turned on my microphone right now. Yes, I'm here.
Any comments about what you just heard?
I absolutely agree with Dr. Heniford. He really, one of the most important things that your group has done is really put this in the forefront. There's a reason why these articles came about, and you see it on the New York Times, and a lot of it is because of the awareness that you've promoted, and it's such an important thing. The reality is that, putting an app out there, putting a mathematical formula, putting a personalized approach to what does this mean for the individual patient, it not only is good for the patients, but you're absolutely right, it brings about an awareness for all of the practitioners, because the reality is that, this is a surgery that for the longest time has been an intern surgery. This is something that, okay, well, we let the interns do this operation and nobody really, it's an easy operation, people will do well. And that's the beauty of the repair. The beauty of the fact that we use tension-free methods, the fact that we use mesh, that we do this laparoscopically and open, it shows you what a reliable operation it is. But you've hit on that's the nail on the head, that we care about patients. We care about their quality of life. And so this approach is so important, because recurrence is not the big deal these days. It is really what is their quality of life and what's their, what is their outcome. So I use your app. I have a patient that came in even today, and when he came in, I saw your app first at the AHS when you guys introduced it. And so I downloaded it, and I've used it with patients, especially the ones that have preoperative pain. The asymptomatic patient, you're absolutely right. The vast majority of them are going to do well. And it's the one that has pain before. I give every patient, asymptomatic, non-asymptomatic, small hernia, big hernia, they all get the spiel about, these are the outcomes. I care, I don't lose sleep about recurrence. But I do lose sleep about the patient who is going to have pain. And so your app is great. I pull up my iPhone, I show the patients, okay, this is you. And it really gives you, it's not just to give them a number. The biggest thing is just to actually tell patients that, look, this is something that we need to all think about, you as the patient, me as a surgeon, and for you guys as the residents and for practitioners, it really gives you an awareness of the fact that this is not, it is a simple operation if you learn it correctly and you do it properly, but what you want to do is you really want to see, what is it that I do in the operating room that's going to impact my patients? And so some things you can control, and we'll talk about that, in my portion of the talk, and some things you can't control, and that's where Dr. Heniford's app is really important, because for the patient that has the sportsman's hernia, athletic pubalgia, some of those patients, their solution is not going to be found in an operation. Sometimes we resort to operative management, but it's so important for them to have honest discussion beforehand of what is it that happens with surgery, what can you expect, and it helps to manage their expectations.
That's correct. I agree. As far as the surgeon, Todd, can you hear me?
Yep.
Do surgeons in the future need to learn more than we've taught them in the past about the nerves and how to treat chronic pain? For instance, I'm going to tell you about a patient who came into my office 6 or 7 days after a hernia repair by another surgeon, saying that she's been in pain ever since, for a week. And she came back a month and a week after with the same exact complaint. She didn't even go back to her surgeon, because her surgeon said, I don't do chronic pain, I just do hernias. Now, I can't imagine this surgeon is alone out there. Are we going to have to make sure that we take this to the next level and start teaching surgeons how to take care of chronic pain?
I think that it's all in the numbers. I mean, I was a math major in college, and numbers are right up my alley. If you think about it, it's the most commonly performed operation in the world, and it's the most common complication of the most. So the answer to that is, of course. I mean, first, indeed, we need to teach anatomy. If an intern's going to put a stitch in, they need to know exactly where that stitch is going. They need to know what type of mesh they're going to use. All of that's got to be part of it. There's no, and the treatment algorithm, and I'll look forward to the treatment algorithm we're going to hear in just a few minutes. By knowing where the nerves are, you can also help prevent the pain, but also help treat the pain. But one thing that we need to be very careful about is if you see another surgeon sees a patient who has chronic pain, don't immediately be critical of the other surgeon. Do a full physical examination, do a full workup. Do not be critical, because you'll be wearing that later. I mean, you need to take a very close look at these patients. One quick patient example: patient had inguinal hernia repair and then had 3 subsequent surgeries in his left groin because of chronic pain. He actually had avascular necrosis of his. That was his problem the whole time. And he really dove in and examined the gentleman. So,
very important. Well, thank you very much, and we'll come back at the end of the conference for some more wide Q&A on everybody's talk. And for those who have just joined, we're in the middle of a live webinar entitled Patient-Centered Outcomes in Inguinal Hernia Repair, Recurrences, Pain, Quality of Life. We have on the line myself, Dr. Brian Jacob, Dr. Todd Heniford, Dr. David Chen, and Dr. George Ferzli, who will be joining us live from abroad when it's his time to talk. So up next is Dr. David Chen from UCLA, who has spent much of his career mastering the anatomy and how to deal with chronic pain. And he's going to teach us about algorithms and treatment approaches for chronic pain after inguinal hernia surgery. So Dr. Chen, thank you very much again for sharing your insight with us.
Thank you, Brian. I really appreciate the opportunity to participate in this, and you have quite an esteemed faculty here, but this is really, it's really an important topic and one that I've spent a lot of time on. I am at UCLA on faculty, and I'm also in charge of the Lichtenstein-Amid Hernia Clinic, and so I have a special interest in hernia pain, mainly because I inherited this practice of hernia pain, and Dr. Amid, who was my mentor, has done probably the greatest amount of work on the operative management of chronic pain after Lichtenstein repair, mainly because they saw patients that were coming back and complaining about pain. Prior to tension-free methods, really people cared most about recurrence, and so recurrence was the big deal, but as we've kind of moved along and quality of life has become the more important measure, we've seen patients that have had pain. The real issue is that, as Dr. Heniford was mentioning to all of you, the key is the best treatment for this is prevention. And so really learning good anatomy, learning that a proper inguinal hernia repair doesn't take much extra time. It requires a rigorous approach to saying, I'm going to do this simple, quote unquote simple operation perfectly, so that this guy that I'm operating on will have the best possible outcome. So I have nothing to disclose here. So some of the background information, as Dr. Heniford already mentioned. So this is really the most common operation performed worldwide and in this country. There's greater than 800,000 inguinal hernia repairs performed annually. And when you look at the incidence of post-herniorrhaphy chronic pain, it clearly is greater than that of recurrence. And so the Swedish Hernia Registry, along with many other large studies, have shown that hernia recurrence is actually the minor indicator these days, and really what we're aiming for is we really need to look at chronic pain. So the incidence of this it's all over the map. You can see that the range ranges from 1% to 63%, and what we kind of use as the working number, what I'll tell a patient in my clinic, is that the incidence of chronic pain after hernia repair, clinically significant, is somewhere in the 5 to 8% range. And really it just is all definition, but that's probably the significant the patient that will have significant impairment from it. If you say, do you have any pain overall, your number is clearly going to go higher up, so it just depends on your definition. The other thing to think about is that this problem preceded mesh repair. So when Dr. Lichtenstein and Dr. Amid formed the Lichtenstein Hernia Institute, they had patients coming to them for hernias, and they really had changed the way that they were going to approach it. They had this protocol that they would use mesh, but also because they were one of the very first hernia referral centers that just focused on hernias, they also had people that came from all over the country for pain. And so this is it's something that, you know, people like to blame on mesh. They like to say that this is a function of our current techniques, be it laparoscopic or open, the fact that we hear about this, the fact that we're addressing it, that this is a problem related to mesh. And the reality is that it really is, mesh plays a component of it, that there are definitely factors related to mesh, but these issues of chronic pain and with similar incidences preceded mesh repair. So as Dr. Heniford mentioned to you, this has really become a very common topic. It's a salient topic for us as surgeons, for patients, and for anybody that really deals with this. And this is just an article on a malpractice settlement this is an $8 million judgment, which is clearly outrageous. But it just tells you that, these are real cases, and this is at the forefront of what we consider to be important. And so it's not okay for a patient to just end up with chronic pain. That being said, some of it is absolutely unavoidable. I read hundreds of operative reports from patients that email me asking for a consultation, and very often you can see, all right, this patient's going to have chronic pain. You read how the surgery was done, what they did with the nerves or what they didn't do with the nerves, and you can actually predict a lot of these things. But it's no longer an acceptable, side effect. This is something that you have liability for it. More importantly, we care about our patients. And as Dr. Heniford showed you, this is in the Wall Street Journal. So this is the popular press. This is people are catching on that, everybody knows somebody who had a hernia repair, or it's one in 5 people. So this is something that needs to be disclosed. We need to be honest about it with our patients, and we need to manage expectations. So in order to treat chronic pain after inguinal herniorrhaphy, so the treatment requires, you need to understand what are the causes of pain after hernia surgery. The second thing that you need to do is you need to understand the groin neuroanatomy. That's for the treatment, but more importantly, if you understand it for the first repair, you could hopefully avoid a lot of the problems that, there's low-lying fruit in terms of preventing many of the cases of pain. You want to understand the technical aspects of the initial operation. It makes a huge difference in how you're going to approach the pain and how you're going to approach the problem, whether they had a plug repair or a Lichtenstein or a lap repair. So all of these things make a difference in what nerves are going to be affected and what are the causes that incite the pain. And you really need a tailored approach. You really need to say, for this patient, what is it that's going on? How do we address it? And the reality of it is that some things you can control and some things you can't. So a lot of it just needs to be individualized. So in regards to post-herniorrhaphy pain, there are 2 broad categories of pain. There's nociceptive pain and there's neuropathic pain. So nociceptive pain it's caused by activation of nociceptors by nociceptive materials produced in tissue injury and inflammation. And these are mediated by A delta and C fibers, and they're perceived as aching, squeezing, stabbing, and throbbing pain. This is really tissue trauma. We would consider meschoma to fall in this kind of category. As well as the postoperative pain. Much of the postoperative pain that patients feel is nociceptive pain. Neuropathic pain, on the other hand, is usually caused by direct nerve injury. And this is characterized by inguinodynia. You can get radiation to the scrotum or the femoral triangle. You get paresthesias, allodynia, hyperpathia, hyperalgesia, hyperesthesia, hypoesthesia, and there sometimes is a positive Tinel sign. The pathophysiology of neuropathic pain, it can be mechanical issues, such as, so you can see, for example, here, this is somebody who here's a nerve, you can see suture material trapped right on top of that nerve, and you can see some mesh material. And here you can see clearly mesh attached to the nerve. And this is a patient that had a traumatic neuroma with suture entrapping the nerve itself. But the reality of it is that if you have just a normal piece of nerve, you can sometimes get structural deformities. And this is actually this is an electron microscopy picture of a nerve over here. And what you see is that it has these crystalline deposits, and you see ultrastructural changes in the nerve just from being in apposition to a piece of mesh here. And so this is just a patient that had this is a neuroma here. This is actually a nerve that was against a piece of mesh down here. And you can see the caliber difference where it actually changes. And when you look under the EM, it had actually, there are ultrastructural changes just from being in apposition without even an inciting, suture on it, tack on it. There was no direct trauma to the nerve except for being in apposition. The other thing that we need to understand is that you need to know the type of repair that's done, because there's a difference between pain after an anterior repair, a Lichtenstein, a plug, a PHS repair, Shoulder, Bassini repair, and there's neuropathic pain after posterior repairs. And so there are open and laparoscopic preperitoneal repairs. So PHS would be considered both an anterior and posterior repair. TEP and TAP are all considered posterior preperitoneal repairs. And so the nerves that are affected with each of these different types of repairs, it makes a difference. So the causes of neuropathic pain after anterior repair. So if you've had a Lichtenstein or a Shoulder or a Bassini, so anything through a groin incision, basically where the mesh sits anterior to the transversus abdominis. So it can be caused by mechanical pressure of a 3D hernia device and meshoma. So basically mesh, a plug, a PHS piece. It can be entrapment by the meshoma. So the mesh can actually, all meshes contract, they can sometimes trap the nerve as they're contracting, or they can trap the vas. They can trap the cord structures as it shrinks. You can get entrapment by suture. This is why it's so important as a resident learning this operation. You should be able to see these nerves every time, and I spend that every operation with the resident. We identify all 3 nerves. I was just in Haiti last week teaching Haitian surgeons, and you can get down to where after you've done 5 of these, you can see the nerve in every single one, and more importantly, you know the presumptive course of the nerve so that you can avoid putting a stitch right through these guys. There's entrapment by perineural scarring. There's traumatic neuromas. Direct contact of the nerves with mesh. When you think about that, it takes your breath away a little bit in that you're going to put mesh in every patient right against the nerves. And so it's important really to keep the investing fascia of the nerves over them. There's always you really don't want to move the nerves around. So you want to prevent damage of the protective fascia of these nerves. After posterior repairs, laparoscopic and open preperitoneal repairs, there's neuropathy that can be caused by pathology in front of the transversalis fascia within the inguinal canal. That's usually caused by fixation devices. When people put a lot of tacks in laparoscopically, we really try and teach where you can use either no fixation or a single fixation tack on Cooper's ligament, but you want to minimize where you're putting these tacks. This is why as residents you learn, your triangle of doom and your triangle of pain. You want to try and not get the preperitoneal nerves, but also when you're tacking straight up against the wall, you can just get that unlucky shot and hit the nerve as it crosses through the inguinal canal. And then there's also neuropathy behind the transversalis fascia within the properitoneal space, just from the mesh being in proximity to the nerves that are in the properitoneal space. So neuropathy in front of the transversalis fascia due to nerve entrapment. You can see here some examples of these are patients that have had basically, this is right here, traumatic neuromas due to fixation materials. And you can see the normal caliber of the nerve. And when you're looking in the groin, here's your iliohypogastric running on the medial side. Your ilioinguinal nerve runs usually on the cord. But these are points when you're shooting your tacks from below. Sometimes you can just get unlucky and hit them. And so it's very important to try and not use them. Here you can see this is a patient that had this is actually a TEP repair, and the patient has tacks that are, you can see a tack right here, you can see another tack right here, and had a traumatic neuroma, unfortunately, just from these fixations. And we've really shied away from using metallic tacks. In reality, does that make any difference on the incidence and etiology of pain? Unfortunately, probably not. It's just that nobody's going to find your tacks afterwards. So it's really, it would behoove you for your patient's sake to practice good technique instead. Here you can see another tack and a piece of mesh. This is and the nerve entrapped right on it on the other side. So then there's also neuropathy caused by behind the transversalis fascia in the properitoneal space. So this is really putting a piece of mesh in the preperitoneal space. We know that it is overall a safe thing to do. We do it every day when we do TEP repair. We do it all the time when we do PHS repairs. And the reality is that the nerves in the properitoneal space are not covered. So there's no investing fascia when the genitofemoral nerve passes over the psoas. And so if you stick a piece of mesh back there and it happens to injure or irritate the nerves, the problem is that they're not protected. Does that mean that it's not safe to put mesh in those places? Absolutely not. You know, I'll tell patients all the time that a lap repair is a great repair. I'll offer it to them, if that, either that or an open repair. I'll give them the pros and cons. You just have to disclose to them that if you're doing a preperitoneal repair, when you have pain, it's just a bigger pain in the butt. And the reason why is that your irritation of the nerves or your injury to the nerves is behind the transversalis fascia. So to get to it is a bigger deal. But the incidence is no greater. So when you look at this, here actually you can see this is a piece of PHS. And you can see here's your very small little genital nerve being trapped by the preperitoneal portion of PHS. Same thing here. This is actually a plug. You can see how it wads up. And these meshes, you can see how when they're in the package and when you take them out of the body, they often don't look anything like what they're supposed to. This one, at least the anterior portion of the PHS is flat, but you can see how the posterior portion can often ball up into a meshoma. Same thing with plugs. And you can see how this is another meshoma that's attached to the genital nerve. And so a lot of times they can either entrap it as it's passing through the canal or even just sitting in the preperitoneal space. When you look at the preperitoneal space itself, this is Bob Fitzgibbons did this cadaveric study, and just to map out these structures, you can see here's your vas deferens, here's your genital branch of the genitofemoral nerve, the femoral branch of the genitofemoral nerve. This is the psoas muscle over here. The lateral femoral cutaneous nerve is here. This would be the inguinal ligament running along here. And then, so this would be your triangle of, your trapezoid of pain is over here, your triangle of doom is over here, but you can see that if you center your mesh in this area with the center of it along the inguinal ligament, if you put tacks across these areas, you can hit the genital branch of the genitofemoral nerve, you can hit the femoral branch, you can get the lateral femoral cutaneous nerve, which thankfully we don't see many people, but they can have pain from that. And then this is up here is where you would, if you shoot through the wall up here, this is where you can get the inguinal portions of the nerves. The ilioinguinal and iliohypogastric nerves are not in this space here. They've already exited and they're coursing above the transversalis fascia. And so that's why you get them through the wall. But these nerves here, the femoral branch and the genital branch, lateral femoral cutaneous, I do triple neurectomies retroperitoneally, laparoscopically. Probably I'm doing about 2 of them to 3 of them a week for patients that have pain. And so when we look at these nerves, you can find them every time, and there's just no covering over them. And so to put a piece of mesh against it, if you get unlucky, sometimes people will have pain, even with a perfectly performed operation. So the diagnostic evaluation. So you want to review all operative reports. You're going to look through, the first operation that the patient had, and then a lot of times they'll have had subsequent operations as well. But you need to look at what was the first operation that they had done. What type of mesh is in there? What did they say about the nerves? Did they even identify them? Sometimes you can predict just from that. They say, I put a running stitch along the conjoint tendon using proline. So you can say, well, if you run a stitch along that medial aspect, you can pretty much guarantee you're going to get that iliohypogastric nerve. Or you'll see people say that, I put fixation tacks along the inguinal ligament all the way. There's incredible things that are being performed out there. And so it really is a matter of we want you especially as a resident, to know this anatomy very well so that you can prevent a lot of the simple problems that are caused. You usually will get a cross-sectional imaging study, a CT or an MRI, to rule out meschoma. Is this really necessary? I think it's absolutely necessary, especially for someone who, if I even am considering operating on them. I see a lot of patients for pain, but I probably only operate on about less than 10% of them, and they have to have failed pretty much all other interventional measures. But if you're going to do that, you want to know what you're up against. The other thing is, like Dr. Heniford said, you want to make sure you're not missing something else. So is there a common explanation? Do they have, diverticulitis behind that? Is there some other anatomic abnormality? And so, but what you're looking for is you're also looking for meschoma. What has the mesh done since the time it was put in there? And MR tends to be a little bit better at looking at these meshomas, but you can see it just as well with CT scans. MR neurography, depending on where you are and who the radiologist is, we see a lot of MR neurograms, and some people will say, they would say that I went all over to have this done, and the radiologists really like to tout it, but it really is of marginal use. Sometimes, the reality is that just because you see something on an MR, if I were to take every patient that was asymptomatic and image them, you probably would find abnormalities too. You want them to have interventional injections. Every patient that I operate on has gone to my interventional pain specialist or an interventional pain specialist and undergone a block, multiple blocks, or ablation. And so the reality of it is that you want them to fail non-operative measures. And recently, what we've been doing is we a lot of times, especially in the patients that we're doing triple neurectomies on, we'll do preoperative and postoperative quantitative testing where they can measure sensory thresholds, and I'll do also pre- and postoperative dermatomal mapping. So that helps you to predict which nerves are affected, and also to identify to basically track your outcomes. Are you really capturing these nerves and getting them relief? So these are cross-sectional images of what a meschoma looks like. This is on CT scans. You can see here. This is a mesh plug right here. Here's another plug. This is a plug here against the femoral vessels. We've seen plugs eroding into the bladder. We've seen plugs eroding into the colon. We definitely are not fans of plugs anymore. And when Dr. Lichtenstein and Dr. Amid, they helped to popularize the plug early on, and people thought it was the greatest thing ever. It made sense. You put a piece of mesh and it plugs the hole, but the mesh has changed so much over time, and we really see a lot of problems related to plug migration and plugs trapping nerves. This is what an MR neurogram looks like, and so they can actually track the course of the ilioinguinal, iliohypogastric nerves. And like I said, it's nice if you have an image that shows you something, and just like when we operate, it's nice if you can see a specific problem when you operate. But the reality is, what something looks like on an image or what something looks like even in the operating room doesn't translate necessarily to what a patient feels. So this is here. If you guys click your full screen, it's probably easier to see this. This is a algorithm for the management of pain after inguinal hernia repair, and this is something that Dr. Lange from the Netherlands. We participated as a group in a chronic pain workshop at the last American Hernia Society meeting and European Hernia Society meeting, and it was a group of multiple people that deal with chronic pain. And this was the consensus algorithm. They've since named it the New York algorithm, and Dr. Lange is working on finalizing it right now. But it's really a pooled survey of about 20 hernia surgeons that deal with chronic pain in terms of what an appropriate algorithm would be in regards to the management of the patient that comes in with pain after hernia repair. And there's definitely variations from practitioner to practitioner on what they would consider their thresholds, how they would approach things. But overall, this is a very good overall framework for how to deal with things. So we'll kind of go through this. So here's your patient that has pain after inguinal hernia repair. And here, this is especially for the immediate post-op patient if they're having excruciating pain, not responding to any analgesia. If there's something technical, especially early on, and they just have terrible pain, that would probably warrant surgical re-exploration to try and identify a specific cause early on. Outside of that, though, most people present in this kind of range here. So pain in the first 3 months after surgery, we still consider that post-operative. So that's not chronic pain yet. So in the definitions of chronic pain, it varies between 3 months and 6 months. But really what we will use is anything less than 3 months is still considered early pain. And so we really just would treat that with basic analgesias, pain medications, conservative measures. And I really would emphasize that the patient that comes back to you, I see a lot of patients that say, I had surgery last week, 2 weeks ago, 1 month ago, 6 weeks ago with this surgeon, and I need to have another operation. Their solution is not going to be in the operating room. And really a lot of those patients would have been much better served if somebody had gone through what to expect with Dr. Heniford's sequel with them. So here's the patient that comes to you after 3 to 6 months of conservative management. So the way this is really the majority of patients that you would deal with. So you look, do they have a recurrence? So if they have recurrence, even if they have recurrence, you still want them to be seen by the pain management services, because you really want to try and discern, is it just pain from recurrence, or do they also have neuropathic pain? And so based upon that detailed assessment, you would say, okay, you're going to need to go back to the operating room anyways. We'll fix your hernia at that time, and then it's plus minus that you would do a triple neurectomy at that time. And the thought is that if they have neuropathic pain and you are going back to reoperate on them, and you probably are going to have to remove a piece of mesh, those nerves are probably done. So at that time, you probably are better off doing a triple neurectomy if they have neuropathic pain. And if they don't have neuropathic pain, that really becomes a judgment call. Do you really go and try and find the nerves at that point, or do you just fix the recurrence? I would say that it depends on how you're going to do it. If they didn't have neuropathic pain and it was a pure recurrence, I would even say that the better way to fix them is to probably use a different, so if you did an open repair before, do a TEP the next time. But that being said, it's complicated because you need to determine, what is the cause of their pain, first of all. But you're going to operate on this person anyways. So here's your guy that doesn't have recurrence. This was a little controversial, and people couldn't decide whether or not they wanted to include ultrasonography or not. But the reality is that it's pretty cheap to do an ultrasound. So I think this is not an absolute, but most people would do a quick ultrasonography just to rule out the occult recurrence. And then from there, with the ultrasound, you would say, do they have recurrence? Is there no recurrence? Or do they have evidence of a meschoma? So if you have recurrence, it's similar to this pathway down here. So you would have the pain management team evaluate them, see what you can get out of that, and then operative correction. And so this would be same thing, anterior correction with triple neurectomy, or posterior correction if they didn't have neuropathic pain. If they have no evidence of, let's go to meschoma. If they have a meschoma, so I would still send them to the pain management team. As you try and see, there's a lot of patients that even though they have meschoma, it doesn't necessarily mean that they're going to need to be in the operating room. They can get blocks still. They can get different, they can get anti-inflammatories, you can get narcotic pain medications, and a lot of times pain will burn itself out. And so here's your patient, and if they fail conservative measures, then you'd pursue operative intervention. They either get cured or they have persistent pain. And for the patient that has meschoma, you need to remove the meschoma. You need to repair any resultant hernia that you've now recreated, and then triple neurectomy in this patient that has meschoma and pain. And these approaches should be open or endoscopic, depending on you're going to tailor that based upon what surgery they had. Now here's the patient that didn't have a recurrence, doesn't have a meschoma, and doesn't have a recurrence. So you get an MRI to rule out any other pathology. So if that shows a meschoma, then similar to over here, pain team, persistent pain, if they have that, you're going to do a removal of the meschoma, repair, and triple neurectomy. Here they mention again, open or endoscopic. So here you have the patient that has recurrence. This patient, if you find a recurrence, they're going to need surgery anyways for the recurrence. You still want the pain team to be involved, and then same thing. This patient's going to end up with the operation, plus minus triple neurectomy if they have coexisting neuropathic pain. And so this is the challenging patient here. This is a patient that you're operating on solely for pain. So no recurrence, no meschoma. They see the pain doctor. They don't have a cure, so they have insufficient effect. And this is a patient that will then say, you've failed all other conservative measures. You probably should have a triple neurectomy. And so when we talk about triple neurectomy, we had done these open for over 550 cases, and in the last, probably in the last 40 of them, I've now switched to doing them laparoscopically in the retroperitoneum if they don't have a meschoma, because you can really access these nerves 100% of the time without getting lost by scar and meschoma and without the risk to the testicle. So the surgical treatment of inguinaldynia, this is kind of the evolution. In 1987, and there are lots of surgeries that were being done before this, but kind of these are the people that have really published specifically for this problem. So Starling in 1987 reported a two-stage triple neurectomy where they come in through the groin to get the ilioinguinal and iliohypogastric nerve, and then made a flank incision to get into the retroperitoneum to take the genitofemoral nerve over the psoas. In 1995, Dr. Amid described a one-stage triple neurectomy, and that's the vast majority of the triple neurectomies that are being done, where all three nerves are accessed through the groin. In the 1990s, both Starling and Amid started to report on this phenomenon of the meschoma. So it was only in the mid-1980s that hernia repair with mesh was really popularized, and so in the 1990s we started to see this phenomenon of meschoma. In 2000, Dr. Amid had modified the triple neurectomy to include the intramuscular segment of the iliohypogastric nerve, and so the nerve runs submuscularly in many patients, and so a lot of times we would miss that portion if you weren't looking for it. In 2005, patients that have coexisting testicular pain, orchialgia, it's a different beast. It's not caused by your ilioinguinal, iliohypogastric, or genital nerve. It's really the paravasal fibers that run with the vas deferens, and so it's misunderstood. And a lot of people, I had 3 guys today that came in with no testicles and still had pain because they thought that somebody thought that an orchiectomy would solve the problem. In 2009, we kind of switched over to getting the genitofemoral trunk in the preperitoneal space for patients that had laparoscopic or PHS or posterior repairs. They really were failing triple neurectomy because you were taking the nerves distal to the problem. And as of 2011, there's been a few descriptions of laparoscopic retroperitoneal access, but no large series, and a few places have been now doing laparoscopic triple neurectomies, including us in the retroperitoneum, because the reliability of finding the nerves is great. So, in our experience of doing triple neurectomies, this is our approach. All patients have more than 6 months. All of them have to fail. They've had ineffective conservative pain management techniques, and they either had no preoperative pain, or if they did, it was not the same pain. This is really where, if we had better tools before, like Dr. Heniford's sequel, we could then tell these patients up front, well, you had this pain before. And a lot of times, that's really, it makes it such a difficult beast to tackle because there's preoperative and postoperative pain. So the triple neurectomy, you really are going for the ilioinguinal nerve, which runs usually along top of the cord, the iliohypogastric nerve, which you can see runs over and then between the internal and external oblique, and then passes out between the folds of the internal and external oblique aponeurosis. Here's the nerve itself here. And then the trick of the iliohypogastric is sometimes you look at this. This is your canal, and you don't see any nerve in here. And so if you pull this fold out here, you can see that here's actually the nerve exiting. But that means the entirety of the nerve is running in the subaponeurotic position of the internal oblique. So there are patients that you won't see an iliohypogastric nerve running its course. So you can imagine, as someone's doing a Lichtenstein repair or or PHS repair and putting some fixation sutures here, if you didn't see the nerve, you have a higher chance of injuring it. This is the subaponeurotic portion of the iliohypogastric nerve. So you can see how this portion runs below, and you wouldn't see it unless you specifically looked at it. So when we do triple neurectomies, we anteriorly, we go for this portion as well. We make sure that we take this nerve in its entirety to where it exits from the muscle. So this is a picture of the same. Now here's your genital nerve. The genital nerve typically should be protected by the cord. And if you leave it within the cremasteric fibers, it's protected. But the problem is that if you do blunt dissection of the cord and pick it up, or if mesh entraps it, that's where the nerve can really be trapped. And you find it most commonly at the lateral cruce of the internal ring is where you can reliably find it running with the external spermatic vein. When we talk about orchialgia, as I was mentioning, it's not caused by the three named nerves. This is really, it's 2 to 3% of the time it will be a patient that comes to you for groin pain will also have orchialgia. And this is a tricky problem. So if you have an open repair, you can strip it. So this is a patient here that had a plug, and you can see the vas running right next to the plug. And he had terrible orchialgia in addition to groin pain. And so this is the plug, and here is the vas entrapped in it. And so this patient already did not want to have kids, and so he had a vasectomy at the same time. And when they looked at the vas, you can see that this is the paravasal nerve fibers. And when this was looked at under the microscope, they could see neuropathic damage of the nerves. And from that, we started taking the paravasal fibers. And the urologists describe a very similar procedure, and for patients that have orchialgia, they'll try and do selective denervation of the cord, and the parasympathetic fibers run with the vas, so they'll try to denervate the vas as well as the testicular artery. And so this is for a patient that has orchialgia, you can actually strip the vas of these fibers, or if they're not looking to have more kids, you can actually just do a vasectomy and transect them there. The key is that this has to be done proximal to the injury. So if you have a plug here, if you have PHS, you can do it at this level. The problem is that if you have TEP repair or a TAP repair and the mesh is preperitoneal, you can't access the vas proximal to that mesh. And so that's kind of the tricky patient that just doesn't have a great solution. And so here's the lamina propria itself, and they look at it and you can see these are nerve bundles that have distortion. So after posterior repairs, this is the same picture. It's the mesh in contact with the nerves is an etiology for pain. It clearly doesn't happen in many patients. You know, there are thousands and thousands of TAP repairs and TAP repairs that we do, and patients do great. It's just when they have pain. It's a lot of times if it wasn't due to a tex being fixed somewhere, it just is sometimes bad luck. It's apposition of the mesh to the nerves. So here, this is one approach where we describe when we were doing triple neurectomies, we'd open the floor. What you're looking at is this is a psoas muscle, and here's the genitofemoral nerve running over that. And so we would extend the triple neurectomy to open the floor and take the nerve there. You can only imagine that it's a bigger operation. It's definitely more involved for the patient. And so really as an approach to that, the first cases of this, there are some cases of single selective neurectomies reported out of Europe before, but no one doing really triple neurectomies. And then there's two groups of neurosurgeons that had described doing this in 2011, just in very small series. But we really have approached this now where if you don't have a meschoma and you've got a preperitoneal repair, this is a nice way to go. You put 2 ports in, you use a separating balloon. This is what it kind of looks like when we put in the balloon. Here's the psoas muscle here. This right here is psoas. You can see here's the junction between the quadratus over here and the psoas over here. This is the iliohypogastric nerve exiting out L1 and the ilioinguinal nerve running down here. Sometimes we'll see that there's a common trunk. You can usually define subcostal nerve at T12, iliohypogastric, ilioinguinal. Below that you'll see, I'll show you, this is the 2 transected. Clip on the iliohypogastric, clip on the ilioinguinal. This is the psoas muscle. Here's the genitofemoral trunk running on top of it. Here you can see a very nice picture of the iliac artery, the ureter. You're looking at the groin over here. The psoas muscle, here's the genitofemoral trunk. So you can see that now you're not dealing with a scarred field. This is a virgin plane. You have a very nice clean field. You can do this operation with very minimal, there's almost no bleeding to speak of. You clearly need to know the anatomy very well, but you can take these nerves. Here's the genital femoral trunk. It bifurcates. Here's the femoral, and here's the genital. The genital is a small branch, but you can take the trunk right proximal to that. But you can also, this is a nice view, but the mesh would sit here if you had a TEP repair. And so you can see just it sitting in apposition, unfortunately, sometimes can cause some problems. And this is the genital nerve right before we take it. So why all three nerves? This is a point of contention. Some people will really advocate selective neurectomy, saying that, okay, if I can predict that the distribution is only the ilioinguinal or the iliohypogastric, you should only take the nerve that's affected. But what we've seen is that, as we said, just looking at a nerve, you can't tell that it's injured or not. Sometimes there'll be ultrastructural changes. This is a patient that, this is a triple neurectomy, and you oftentimes will see things like this. You'll see a little neuroma, you'll see a cut in, you'll see a suture on it, you'll see some mesh against it, but oftentimes the nerves look fine. Why take them all? So when you look at selective neurectomy, you have some series, and this is kind of about the correct range. It's about the 60 to 70% efficacy rate when you do selective neurectomy. And it's a very imprecise science, because really you're asking patients, are you better, but what does that really mean? And a lot of times it's overall, did they have some measurable effect? Are they taking less pain medications? Are they better off? When you look at triple neurectomy, this is a larger series, and here you see efficacy rates in about the 90% range. And here, these are the complete responders. 72% had no pain, 85% had no pain. So this is the other reason that you want to do it, is that we see this so clearly now when we do, I looked at over 100 cadavers looking at the retroperitoneal anatomy. But even when I do these triple neurectomies, you can see in many patients there's only one trunk of the iliohypogastric and ilioinguinal, or we see where there's crossing fibers, or we see where the nerves, where the femoral branch and the genital branch of the genitofemoral, there'll be multiple branches. So there's so much neurologic variation that when you go in to operate on one of these patients that has pain, you want to take all of these nerves out of the mix because you're not going back. So here's the conclusions of the operations that we know. We know that triple neurectomy is the best available operation for patients that have neuropathic pain. Meschoma, if you have it, needs to be addressed. Orchialgia is a different beast, and you have to think about, how are you going to approach it. But you oftentimes will need to do a paravasal neurectomy. The neurectomy, this is the key. You guys need to understand what operation was done, and when you're doing it, trying to prevent it. But you need to do a neurectomy proximal to the injury. I see a lot of times patients that have TEP repair and subsequently they've had a subsequent triple neurectomy in the groin. It's not going to help them. So the injury was proximal to that. You need a tailored approach, and the biggest thing, just like Dr. Heniford said, prevention is key. So even recognizing that this is a problem will make you more aware when you do your next hernia repair. Thank you very much for allowing me to participate on this panel.
David, that was phenomenal. Can you hear me?
Yeah, I can hear you.
Yeah, really terrific. Again, every time I listen to this talk, I learn something new. And so I can only imagine that people listening for the first time are overwhelmed with your knowledge. And, it's very clear to me as I host this that when you perform in this country 800,000 operations with an incidence that's probably coming in at 10%, that means we've got 80,000 new cases of groin pain every year. So yeah, that's going to be a lot for you and Parviz to handle. So we're going to need a subspecialty. Dr. Matthews is online and was throwing out some new coined terms. But really, this is something that even as I enter the world of hernia, I'm realizing how humbled I am by the knowledge base needed to do this. And we really deserve to teach this as we go forward and tease out of what you're presenting what is anecdotal, what is true, and whatnot. There's some questions that came online that I'm going to start with. And Dr. Ferzli, are you online? We can't hear Dr. Ferzli. If he comes online, we'll get him.
Hi. I can hear you. Can you hear me?
Yeah, we can hear you perfectly. Welcome from Beirut, Lebanon.
Thank you. Okay, go ahead, please. Thank you. That was excellent, Dr. Chen. Superb, indeed.
Thank you. I see some questions here that people were typing. So one thing is anyone using self-adherent mesh for open or lap inguinal hernia repairs? Definitely ProGrip, and same thing with using fibrin glue. There's lots of different options for fixation of the mesh. And when we look at that, there definitely is some promising data on, is it going to decrease the incidence of pain? Definitely you take out of the mix some of the problems in terms of fixation. In terms of, is it going to be as durable a repair? For the small hernia, I absolutely think so. For the larger hernia, to not put any fixation, sometimes we think about, is that going to cause a recurrence? A lot of times you'll see when you look at even those studies, if you tease out the details of it, there's a fixation suture put at the symphysis when people put in fibrin glue at their discretion. And if you've worked with ProGrip, it definitely, that stuff really sticks. And so it definitely is a viable option for fixation. We just don't know the long-term effects of these little PLLA hooks, because they definitely cause, they're incredible. They can stick very well. So putting that in apposition to the nerve, if the nerve has its investing fascia, it probably is okay, but it really still emphasizes the need for proper technique. In terms of other questions, I saw another one here. How good is the triple neurectomy, and what are the side effects of triple neurectomy? And what do we do when it doesn't work? That is a fantastic question, because the reality is that it is not the fix-all. It never will bring patients back to what they were before surgery. That's the thing, is that's why I really stress to patients that if you're going to have surgery, you need to have failed all conservative measures, because it is not, the best thing since sliced bread. It is, for the patient that has intractable pain, very helpful and usually very effective. And so we really do have response and success rates in the 90% range. What does that mean? That's a number. Is it if their pain goes from 8 to 6? Is it 8 to 4? Is it, what quantifies success? A lot of it is that success would be defined by us as we'll often tell patients that, we would like you to be 100% better, but probably a more realistic expectation would be that they would be about 80% better, that we would hope that they would have less reliance on narcotic pain medications, or in a lot of cases they could come off of it altogether. The main thing is really goes back to what Dr. Heniford said. Do they have a reasonable quality of life? Because here are patients that they can't work, they can't do anything, they can't think, they can't function on a day-to-day basis. And a lot of times, it will take them out of that intractable pain and terrible quality of life to functional. And that's really what we're hoping for. If I can get someone to no pain, I mean, that's fantastic. But to get somebody improved and functional and happy with their repair, these are patients that have gone through really hell, and they really are looking for anything at that point, and they tried all different kinds of things. So what are the side effects? All patients will be expected to have a patch of numbness, and so they're going to have numbness of their iliohypogastric, ilioinguinal, and the genital distribution, and that in of itself is not, that's not an insignificant effect. It is as important as it is to disclose up front with hernia surgery. It's even more important to disclose up front with triple neurectomy that you're not going to be normal, you're going to be numb there. But for the patient that really has neuropathic pain, they would trade pain for numbness 100 times out of 100. Now, are there patients that can get worse or don't get better? Absolutely, and I specifically tell each patient that there's a chance that you won't get better, and there's a chance that you could even get worse. And if we think about why they could get worse, the main cause of worsening pain is usually deafferentation. That when you take out these nerves, when you cut them, sometimes your central nervous system doesn't know what to do with the lack of input. And so we don't see a lot of it. We have very rare cases of deafferentation. Since I've been doing retroperitoneally, where you really are taking the nerve proximally, I've seen it a little bit more, where out of 30 patients, I've seen 2 patients with that, and usually it's self-limiting. They say, I was better for 2 weeks, I was totally numb, and then suddenly I had this burning pain, and they have no idea what to do with it. And thankfully, it's burnt out. One of the neurosurgeons that I work with has done thousands of rhizotomies for patients with cerebral palsy, and that's really where deafferentation was most well described. And so these kids that had CP, they would cut the nerves, and some of them would get deafferentation, and almost uniformly he had said that his experience was it was transient. But that's something that you need to tell patients, that there's a real possibility that you can make them worse.
So David, we have a couple questions we have to get through real quick. Dr. Heniford's group published a paper back in November looking at the number of tacks, and they saw a significant difference in the amount of chronic pain when there was more than 10 tacks used.
Yeah, absolutely.
In your chat, specifically to fine-tune the question for you, you talked about how these tacks can get in there, and you just brushed on the absorbable tacking. Maybe you or Dr. Heniford can comment your thoughts about replacing the use of permanent tacks with absorbable tacks in the inguinal hernia repair, and what you think about that.
Right.
And I'd like to hear from everybody on the panel real quick.
Yeah.
Well, what we saw in this study was that if you use greater than 10 tacks, and we didn't pick the number 10, the data picked number 10 for us. If you use greater than 10 tacks, you had significantly more discomfort after a laparoscopic inguinal hernia repair than if you used more than 10 tacks was worse than less than 10 tacks, and dramatically so. One of the interesting things is that surgeons have migrated to absorbable tacks, thinking that it's a free shot, let's say. And what we found is that surgeons are much more likely to use greater than 10 tacks and even greater than 20 tacks if they're using absorbable tacks. And that does not prevent discomfort. Tacks are tacks, whether they're absorbable or not. Many of them last for months and months. And so using an absorbable tack, the key here is use them the same that you would use a metallic tack.
Dr. Ferzli, what do you think?
I really don't think that, can you hear me?
Yes.
Yes. I really don't think that non-absorbable tacks should remain on the market, not only because of the inguinodenia, but because of the injuries to the surrounding structures. And the same apply not only for inguinal hernia, but for hiatal hernia, where they can migrate into the pericardium and cause tamponade. And often we see them now in the bladder and into the colon. So at least by removing the non-absorbable tack, we've eliminated some problem with the tacks to start with. I honestly don't see any reason, I agree with Dr. Heniford, to really use more than 3 or 4 tacks. I mean, the question is, and Dr. Andrew Wright just started here, that we really should have the prevention, as Dr. Chen mentioned, is extremely important. We have to all have a consensus that if you are going to tack, where are you going to put the tacks and how many tacks you are going to put. And certainly the absorbable, without disagreeing with Dr. Heniford, it's probably better.
But if I may, Brian, one of the interesting things, people have started using glue. And in this same study, using glue, patients did extremely well out of the gate if you used glue alone. But unfortunately, at a year, these patients were much more likely to complain of feeling that their mesh has shifted or discomfort compared to patients who had tacks. And the odds ratio was greater than 3 for those patients compared to patients who had tacks. So it's interesting, at least in this study, when there was over 1,700 patients, the patients did really well to begin with, but then later, glue wasn't as effective as tacks.
I agree. And we have some data coming out in the next few months looking at laparoscopic fixation with self-adhering mesh. In some patients, we have a small cohort on one side, this type of repair on the other side with tacks, and just in the same patient, blinded, and what their experiences are. But I agree. I think a lot of this sensation of pain is dependent on that comfort scale beforehand and what happens afterward, and a lot of it is related to what was the more symptomatic side and how symptomatic they were. I do believe that this deserves a specialty team, and there's not enough of them out there. And as I just typed, somebody asked, from the University of Washington, Dr. Wright asked, how do you, as a resident, get more exposed to these types of patients? And the truth is it's a challenging question because they only come to certain centers, and then when they do come,
Correct.
we don't have a set management team yet. So this is really wide open for the creation as we go forward, blending prediction and then treatment for all these 40 to 80,000 new cases a year that are going to be coming down the pipe. So I do think we need a team to do it. We have to keep on time. We've only got 40 minutes left, and then we have to log off. We are live here for those who have logged on with the patient-centered outcomes in inguinal hernia repair, recurrences, pain, quality of life. We've got Doctors Todd Heniford, George Ferzli, David Chen, and myself, Brian Jacob. Feel free to type in your questions for us, and we'll answer them as best we can. If we don't get your question, just retype it. Sometimes it gets off the screen. Moving forward, we're grateful that Dr. Ferzli can join us live from his travels abroad to begin the discussion about recurrences and specifically an overview of the causes of recurrences. And I've heard this talk before, and I think it's a phenomenal talk, and I'm looking forward to learning more about it today. Thank you, Dr. Ferzli.
Thank you all, really, thank you. And as soon as I get my slide. Now, one of the reasons we should all, as practitioners for this very common disease, to know more about the causes of recurrence is because not only like the growing pain, we have to discuss it with the patient. Now, there are certain things that we can do to certainly prevent them, but there's okay, we got it here. So certain things that are patient-related. I am going to, okay, bear with me here. Okay, nothing to disclose. And the evidence that's going to be presented is going to be all based on level of evidence. I cannot get that slide. Forgive me. Okay, well, the numbers in parentheses reflect the level of evidence of every factor in the patient-related causes. And the level of evidence, very briefly, go from 1 to 5, where 1 is the best, is the most robust, which is basically a randomized controlled trial, all or none studies, and 5 is the expert opinion. And then in between, we have the meta-analysis and the cohort trial and so forth. So when we look at the gender here, which is a male has a higher incidence of recurrence according to the data than female. We have to keep in mind here, very important as practitioners, that femoral hernias are more common in female, and they may lead to a cause of recurrence because of missed hernia. And that was from the early 90s. As far as age, the older the patient, the higher possibility of recurrence. The family history is significant. This has been described in Europe from the Netherlands and multiple publications. Always ask your patient if they had a family history because it may contribute to the discussion with the patient that he may be at a risk of recurrence. Collagen disorder with inversion of 1 to 3 as level of evidence. Similar etiology believed to be for AAA, aortic aneurysm. Smoking is significantly a factor, and here we can do something with the patient by asking them for smoking cessation, which has been really implicated smoking in colon leaks and so many other things indeed for recurrent hernia. We all intuitively believe, agree with obesity as being a cause of increased incidence not only of seroma and infection and so forth, but certainly of recurrence. Now, when you're operating on a recurrent hernia, there's strong evidence that the number of recurrence, the more you get a recurrence, the higher likelihood you're going to possibly get a recurrence. So that is also a very important factor, is to inquire and especially get the prior operative report here. Try to always, whenever you are going to do a recurrent hernia, if you can, fortunate enough to get the old operative report to know what was done open or was it done laparoscopically, please take that message home. This is perhaps one of the most important things from my perspective. Steroid, prostatectomy, appendectomy, and diabetes have been implicated, and we all, again, intuitively, the ascites and the peritoneal. So as far as the patient, the causes of recurrence, we can help with the weight loss. We can help with the smoking. We certainly cannot do much more with the other. Now, the type of hernia may implicate us as surgeons in a higher possibility of recurrence. When you are faced, for example, with bilateral hernias versus for incarcerated and strangulated, large defects, especially bilateral direct hernias, and again, the femoral and the scrotal. Now, these are obviously situations where if I get a scrotal or a femoral or an incarcerated, I cannot do something about it. So we just have to be aware that this can increase the likelihood, which will mandate from us as surgeons or herniologists to be really more careful as in every case because of the high incidence of recurrence. Now, when we come to the operating room, we are going to start with actually the anesthesiologist. And this is a team where everyone is going to contribute to a recurrence. We all know that regional anesthesia has a higher likelihood of urinary retention. This is level 1 evidence. Northern had shown that local anesthesia increases by itself as an independent factor the incidence of recurrence of a hernia. General slightly increased the incidence of general anesthesia complication, but not the recurrence. When you go to the Mayo stand, where the nurses, obviously the mesh size is extremely important, the wrong configuration, a keyhole, this still remains debated and published recently. Obviously, no keyhole is a consensus in most of the world, actually, that the keyhole from the time of Ed Felix and Ed Phillips and certainly the mesh should not have a keyhole. The assistant here, there is some conflicting, but obviously there is no difference between attending and resident. However, the lower the PGY level, the higher the incidence of recurrence. So, and now we come to the surgeon, who is the most important factor actually in deciding what is good for him to do, how comfortable he is in doing laparoscopy or open. And indeed, the experience and the learning curve, and more importantly, the frustration during the surgery has led to obvious incidence of bad repair and recurrence. Now, should we do TAP or TEP, for example? Cochrane level 1 evidence, no difference, because obviously it's the experience of the surgeon. The open versus laparoscopic, when we look at one outcome, which is recurrence, level 1A. This is a very strong level of evidence. Mesh versus tissue repair, obviously we all know from the 1980 in the New England Journal of Medicine paper that mesh decreases the recurrence rate, so therefore we have to use mesh. Now when we come to the technique, obviously, I'm going to show a video here that is very brief. I hope it plays. Mr. Lambert. Now, this is a patient that was brought into the operating room to repair extraperitoneally a left inguinal hernia. Please keep with me in mind a left inguinal hernia. We could see the rectus muscle on the left up here and the pubic symphysis in the middle here. And now we're looking at the Cooper ligament on the right, the surgeon trying to explore the right side before going into the left side. And then looking at the femoral canal here with the one-handed thing, and now we have some bleeding. Obviously, this starts the frustration that we are all have been seen, and so we continue on the now on the left side, trying to figure out what is going up. And then again, there's a peritoneal tear here. So now we're losing the pneumo, and we still see that, to me, this is a direct hernia. So continuing to try to, instead of doing traction, counter-traction, just to pull down with one hand. So now the camera gets again because of the pneumo. How did we don't see well, and we go back in, the trocar comes out. The trocars seem to be very close to each other. The trocar should be away from the pubic symphysis as a basic rule, and now again the bladder, which should be empty, somehow the defect is seen. We could see that the myopectineal orifice has not been dissected totally, neither on the left, neither on the right. We don't see the space of Bogros, and we don't see the vas deferens. We don't know if there is a pantaloon hernia, if there is an indirect and a direct. We did not go, the trocar comes out now when the mesh is inserted. The camera is dirty. The camera trocar is placed back in. Now we are tacking. Notice we're tacking on the right side, super, and the midline pubic symphysis. We're not doing anything on the left where the hernia is. So basically now the mesh hardly comes to the defect on the left. So basically there you go with the trocars very close to each other. So basically we could see in this brief 2 minutes how one can do a hernia repair. Can you go back to the slide, please? How we can go back, we do a hernia repair, and suppose we come out of the operating room with the mesh placed in the midline, more so on the right, tacked on the right side, not on the left. We don't know if the mesh did not even go to the left end of the superior iliac spine as it's supposed to do. And, you know, again, we don't even know a proper exposure of the right side, if there was an indirect, if the intent. So certainly, this comes to the failure to expose your orifice. Indeed, a missed lipoma, it's a great idea to always find the lipoma. Actually, it will give you, especially in scrotal hernia and in large indirect hernia, a better delineation of the hernia sac. So it's always in the upper outer quadrant of the indirect ring. Missed hernia, which is typical as you saw in the thing. We don't expose the femoral canal or the obturator, and the fixation. Now the operative time, interestingly, this was a paper that came in 2011, same group, Bender, Linden, and Norden, where they looked at the operative time. And the main thing here, obviously without going too much into the paper, is that when the surgery was done very fast, in less than 36 minutes, there was higher recurrence rate than when the surgery took more than 1 hour or 66 minutes. Obviously, what is meant by this is that you're speeding, you're being sloppy, you're being careless, and you're really not doing a good job. And we have to go back to the principle of by Halstead that if we are bright and yet fast, that we should be very thorough and safe. And this is really another extremely important thing to prevent growing pain that Dr. Chen, even Dr. Heniford, and Brian, and everybody, I mean, this is where it starts, actually. Finally, obviously, the complications can, unfortunately, also not help us in the recurrence rate, which is basically if you get an infection, you have to remove the mesh. Migration, as Dr. Heniford said, a year later, hematoma or seroma does not allow the space to plicate properly. And then the nerve injury, which by itself is another exploration, which is very similar at the end of the day to a recurrence. So the message briefly home take is please know your anatomy, extremely meticulous dissection, and do what you're comfortable with. Choose your modus operandi and just do it. You're comfortable open, do it open, bloodless, meticulous, thorough, slow. Otherwise, you know, you're really going to have a problem post-op. I thank you very much, everyone. Thank you very much for your attention. If we have any question, please let me know. Thank you. Can you hear me?
Yes, George, we're all here. Thank you very much. What we're going to do, because Dr. Heniford has to leave promptly at 9, is we're going to go right into my talk, which is a perfect segue. It's also about recurrences and more about technique, and then we're going to do a recurrence conversation blended with a final discussion at the end. Is that okay? And assuming that the answer was yes there, we're going to start my talk again. For those just logging in, you've joined the live webinar. This is the final talk during patient-centered outcomes in inguinal hernia repair, recurrences, pain, quality of life. You're joining Drs. Todd Heniford, David Chen, George Ferzli, and myself, Brian Jacob. And I'm coming here live from New York City. And again, thank you to the Resident Education Committee, Drs. Catan and Matthews, and the rest of SAGES for this opportunity to chair this event. And Thank you very much to my faculty for being here. You can't do it alone for sure. And these talks have just been phenomenal. We've heard over and over again, and we're hearing again now, a resonating theme, which is that to have a successful outcome, you need to blend not just mesh and fixation, but a mastery of the anatomy and technique in the right patient at any given time. And so it's to complete the pie, you really have to consider all the different options. We just heard a brilliant talk with evidence-based how these hernias can recur. But just to reiterate, some of the more technical aspects is that it can be from a technical error, and that technical error can come from inadequate coverage, inadequate mesh fixation, not adequately repairing a hernia during an initial operation, and none of these things are ever going to be intentional. These are repairs that you believe you're doing correctly at the time, but simply don't. And recording videos videos of your operations as you go and then looking back at them afterward is a real nice way to learn what you did and didn't actually do. Some of the products do shrink or migrate, and so even though you leave them in one spot, doesn't mean that's where they're going to end up. And of course, patient factors. Now, this is what mesh looks like when it shrinks, and what you see here is a video of it showing of what a very large direct hernia can look like, not necessarily how cavernous it is, but look how far medial it comes. The medial extent of the direct hernia is very close to midline. And what you have to appreciate when you're doing a laparoscopic repair is that if you don't get wide overlap, if that mesh doesn't come all the way past midline and you just bring it up to Cooper's, you're going to get a recurrence, a medial recurrence in that one area. And so there's a lot you can learn through laparoscopy about the etiologies of these recurrences as we learn more of our experience. And we talked about fixation. Fixation has to be placed judiciously. It's okay to tack into Cooper's ligament. It's okay to tack into regions where you know there's no nerves. But excessive use of tacks is not something that's going to lead to good outcomes over time. And this is one of my earlier cases where we did still use permanent fixation. We've moved since 2009 to minimal fixation or no fixation. I have personally used a self-adhering mesh for most of these cases, and we'll be producing our results in the upcoming year. We've done this now for 3 years, and we've got pretty good follow-up for those 3 years. But what you can see is that self-adhering mesh eliminates the need for any fixation in certain patients and certain hernia repairs, but it does still expose mesh to the potential anatomical location of the genital femoral nerve as you move forward. The incidence of recurrences is pretty much identical between laparoscopy and open. And in laparoscopy, we talk about TAPS and TEPS. There's a whole range of recurrence rates. But if you take an experienced laparoscopist and compare it to an experienced open hernia surgeon, recurrence rates generally turn out to be the same. It's when you start comparing apples and oranges with inexperience and experience that you get differences. In fact, there's good literature to show that there's probably at least 1 in 5 hernia operations that are done for the purposes of recurrences, and that even this number may be underestimated. For some reasons, definitions of recurrences will vary. 2, long-term follow-up beyond a year is poor. 3, not all patients recognize or even complain of a recurrence or go back to their original surgeon. And finally, not all recurrences undergo reoperation, especially if they're completely asymptomatic. Whether or not to do a repair open or laparoscopically is going to depend on your belief on your clinical experience or the data. Certainly, in certain populations, especially in Europe, the open repairs for recurrences are very popular. And Professor Campanelli has spent time since 2006 describing ways to classify recurrences, and he breaks them down into an R1 recurrence, which is basically a dilation of the internal ring, or an R2 recurrence, which is more of a medial type of recurrence near the pubis, and then finally an R3 recurrence, which is a breakdown of the entire wall. And he talks about using a plug to repair an open repair, R1 recurrence, which is just to repair that internal ring, or a Wantz type repair where you use more of a midline incision to get into a virginal plane for those medial pubic tubercle recurrences. In all three, he suggests that you can use laparoscopy as a way to fix these, but you have to add general anesthesia, and for some patients, that becomes an issue. And in some areas of the world, cost becomes an issue, where they don't always have the cost and equipment to perform laparoscopy. But the bottom line is that there are a large number of ways, specifically in the open arena, to tackle recurrences. Is there any data to support laparoscopy? Because for me, at least, it's how I was trained. It's what I've been using for the last 8 years, and so I'm pretty familiar with it. But there are randomized prospective trials out there, albeit they're not the best type. They probably fall into Dr. Ferzli's level 2 category. But this is one that's out of Greece, which looked at 82 patients who had recurrences following open repairs. They excluded some of the giant inguinal scrotal hernias to keep the patients somewhat similar, and they were randomized, and 24 got TAP, 26 got TEP, and 32 got open Lichtenstein repairs. They followed their patients for 3 years, which is a respectable amount of time if you're going to pick up recurrence or chronic pain. And they looked at those pain scores and return to normal activities going forward. And what they found is that there was significantly less pain in the laparoscopic group compared to the open group, and no significant difference in recurrence rates at 3 years. They did humbly admit that statistical significance would require 155 patients in each group, so they did not reach statistical significance. But it was a start at randomizing this challenging group of patients into some sort of outcome variable broken down by technique. Last year, Savonius published a retrospective review of almost 20,000 reoperations from the Swedish hernia registrar with hernias that were done between 1992 and 2008. And using the laparoscopy approach as a reference standard, found that taking a recurrence and just doing a suture repair had 2.5 times the hazard ratio, 2.5 times the incidence for another recurrence, almost as much for a plug. The Lichtenstein broke that down to only 1.5 times, but an open pre-peritoneal mesh repair was only 1.36 times the incidence of a recurrence compared to laparoscopy. And what they concluded in that study was that laparoscopy and the open pre-peritoneal repairs were the two techniques associated with the lowest risk of reoperation following an open recurrence. The long story short is surgeons who specialized in one method of hernia repair appeared to have excellent outcomes whenever they operated, and this, believe it or not, took a study to prove as well. And this was also teased out from a meta-analysis when they looked at laparoscopy and for recurrences and saw some of the same advantages that we know of already, which is basically you get magnified anatomy. It permits a very wide mesh overlap, which we know is going to be a key in a lot of these hernia repairs because it's going to optimize tissue ingrowth and stability. Plus, you blend fast recovery, a quicker return to work with almost no wound complications, which is very, very true. Now, there's minimal chronic pain, but it's not zero, and that's for reasons that we just learned. And remember that data, even randomized prospective trials, is not going to always dictate what's best for your patient population. For me, I use TEP. I do about 120 a year or so myself, but it's not always what you need for every single recurrence, and this is very important, and we can debate this afterward. But if you took, and I'm not sure, did I miss a video here? If you look at patients who come in after an open plug repair, I'm sorry, this is not after an open plug repair, but my videos weren't starting. This is just showing how a laparoscopy compared to open can really optimize anatomy, and what you see here is a femoral hernia that was missed on a previous repair done open. Okay, and so laparoscopically, at least when you're trained to look at all three defects, you really do get a better visualization of the three places where hernias can be. And I don't know about the other panelists, I'm finding little spots within the myopectoral orifice that little pieces of fat can get stuck into that I know I would have missed in an open way that aren't even typically described. But here's a nice femoral hernia, so magnified views are very helpful laparoscopically. Here's a woman who underwent a right open plug repair about a year before she came to see me, and she's been having chronic pain ever since. And when we went in laparoscopically in this virginal TEP plane, we found this femoral hernia again that was stuck up in there and probably missed during the first period of time. She had gone through pain clinics beforehand. She had gone through CAT scans. The CAT scan missed this, but we were able to reduce this femoral hernia, pull it out, and then what you can see here in the video, this is the lacunar ligament. This is Cooper's ligament over here. Here's the fat already reduced by the yellow arrows. And what you see here bulging down is the plug. So the question is, what do you do about that plug? Can you take out that old plug laparoscopically? Personally and anecdotally, I believe that you should, not knowing whether or not that's actually causing her discomfort or not. And you can do this laparoscopically simply with a hook cautery by pulling it out. The question is, what do you do with that defect right now? And then you're going to put mesh in like you would in a standard lap TEP to repair this case. But I do think laparoscopy is very good for recurrences after open plug repairs. And so I put that over into the category on the left of your screen. Now what about recurrences after an open mesh with preperitoneal space? So this was a patient who had had a PHS system placed. And you can see in the middle of your screen the preperitoneal portion of that disc sort of shriveled up right now. And what's happened to it is if it was at one time covering the internal ring, it no longer is. And so through a laparoscopic technique, we're able to see the cord. You can see that disc of the preperitoneal portion of it. And then you can see that there's a small, tiny, indirect hernia that's caused this patient some discomfort and is considered a recurrence. And so I do believe that laparoscopy is good after open repairs with mesh in the preperitoneal space as well. What about after an open Lichtenstein, so an open approach with anteriorly placed mesh? And again, for the experienced TAP or TEP surgeon, this is another way to do it. What you'll run into, as you can see here, is that there's a little bit more scarring around the internal ring, and you may need to use electrocautery or a little bit more dissection to reduce the hernias in these patients, because there can be hernia sac that's either stuck to the mesh anteriorly, or a lot of this is high ligation of the sac. Some of the sutures stuck to the surrounding tissues. And so through careful dissection, you actually can reduce a lot of these hernias using a total extraperitoneal technique, which is why for recurrences after Lichtenstein, I still like to start with a TEP before moving forward with other techniques. Laparoscopy, to me, is the optimal diagnostic tool after a TEP or TAP repair where you have a recurrence. So here's a TEP repair. You can see some of the clips that were placed on the peritoneum before. But if you look medial, this is a medial recurrence, and so according to Campanelli, the R2, in the middle of your screen, you can see a hole right above Cooper's ligament on the right. And what probably happened here is the mesh pulled away from that region and uncovered a formed direct hernia, or it formed since then. And then using laparoscopy, when you see that defect in the middle, you have a number of options of types of mesh that you can place. Specifically, if you've ruined your peritoneum, there are barrier-coated meshes that you can insert and permanently fixate to Cooper's ligament or even to the peritoneum with non-absorbable sutures. Very careful to identify and understand where your nerves are going to be. This is just another example of a recurrence with a very small defect done after a TEP or a TAP repair where the patient felt a bulge, and even laparoscopically you don't really see it as well, but when you start your dissection and you realize this again is the left groin, down at the bottom of your screen is Cooper's ligament, and you can see that there's a definite recurrence right here where again the mesh pulled away from that one spot of fixation underneath that space of Retzius there. And through laparoscopy, you can dissect that out and then get a very good overlap. And you can see here just the left cord and how medial that recurrence actually is and how laparoscopy helps with the diagnosis. So after a TEP and TAP for small defects, I do like to use laparoscopy to make the diagnosis and perhaps even proceed with the repair. Now what about large defects? And this is one of my own cases where we didn't appreciate the actual size of the defect, and he came back at about 6 months with a recurrence. And we used a very large 7-inch wide piece of mesh, and you can see the entire hernia sac was made up of that large piece of mesh. And so here we had to pull out a few other tricks in the book where you can actually suture laparoscopically to get your retroperitoneal fixation, and then use some other standard lap ventral techniques, because you still have to bridge a defect here, but you can get a 20 centimeter or even larger piece of mesh in for these large giant hernias, where if you tried to close that 10 centimeter defect under tension and open, the gentleman would still have a high chance of recurrence because of tension. So in certain cases, and I saw this patient, he's about a year out now, so far he's doing okay, and he had a seroma which he did resolve. And you can see that this is a photograph of his right groin now afterwards, still doing well. And so for large defects too, I'll at least start with a laparoscopic diagnostic approach and see if there are ways to fix these patients. When do we not use laparoscopy? Well, first of all, when the patient doesn't want it or has reasons to benefit from it. So like you see in this picture, that patient doesn't have any benefit from a laparoscopic approach, probably can't even get in that cavity. We're not going to do that. And then perhaps the biggest one is if it's contraindicated to use general anesthesia. And finally, if a surgeon is not comfortable with laparoscopy, this is not a time to start. This laparoscopic approach is for the people who are used to it and have done hundreds of them open beforehand. And so for that reason, when I teach, I think it's important to understand that after tap and TEP approaches, it is okay to put this approach to an open technique and do what you're comfortable with to fix these types of repairs. Now these are the rare cases you're going to see come in. This is a giant inguinal scrotal hernia. This is not the kind of thing you're going to do laparoscopically. You may want to do it just to look inside and see what's going on. This is just a video to show. Here's a CAT scan. You can see a lot of this loss of domain, abdominal contents in this gentleman's scrotal area. And you can see laparoscopically, we didn't put the laparoscope in order to fix this, but to see what we were going to deal with, assess domain. And you also had an umbilical hernia. But this is what you're going to do. I call this the two-hand approach, which didn't work, and we had to go up to the five-hand approach. In order to get these hernia contents reduced, we did a prophylactic orchiectomy. Here you can see the shelving edge of the inguinal ligament. You have to be very careful, even in these patients, to identify the nerves, do a primary repair with an onlay. And again, we had an orchiectomy here to avoid some of the testicular complications that we figured this was going to come with. But I just showed this one case to show some of the reasons why we don't use laparoscopy. This is just his post-op picture. Some of the other reasons, every now and then, very, very rare, you can get a bladder injury from laparoscopy. This is a video that I borrowed. And you can see here, when you put your insufflation, you don't want to see urine coming up. Not a good sign, not good for the hernia repair, and also rarely seen with an open technique. So if you have patients who have had prostatectomies in the past, think twice about using laparoscopy before you proceed. So for high risk of visceral injury, I put those patients over into the open approaches for recurrences. In conclusion, I think that laparoscopy provides an accurate magnified diagnosis. I do think it's best for recurrences after previous open or anterior repairs. I think it's preferable, at least as a diagnostic tool, when previous repairs done with mesh in the preperitoneal space present. And you have to eventually use the technique you have the most experience with. Or if you don't think that your experience is best for that patient, don't be afraid to refer them elsewhere, because you don't want to create more harm than good. So thank you very much for your attention. And now we'll join everybody live. Clicking on Start Sharing. I see myself.
Yeah, I'm on.
Yep.
I think the microphones are on, just the webcams aren't.
Okay, good. So, again, for anyone who's still listening in, you're at the tail end of the live webinar on patient-centered outcomes, where we just covered recurrences, pain, and quality of life. Dr. Ferzli, live from Beirut, you gave a tremendously detailed talk about evidence-based medicine and recurrences. And the question I have for you is, what additional steps do you take during a workup when you have a recurrence compared to your original patients who present who don't have a recurrence?
Well, first and foremost, as we stated before, is to make sure we know what the prior op report was. Because as you mentioned, a simple plug and patch repair from above, when you go laparoscopically, really, honestly, you're lucky with that plug. That was easy to come out, to cut with you with the cautery. We get those huge plugs that you break a scissor, ligature, harmonic, and you still can't get the plug out. And the plug is sitting on the vein. So the open approach with a plug should alert you a lot as to what you really may be up to. The other thing I wanted to add, your talk really, Brian, was superb. I honestly believe that the scrotal hernias, even the ones that you have shown, but obviously this is a level 5 expert opinion, as we say, level 5 evidence, which is not certainly one. I really believe it is the most beautiful operation to do via TEP, laparoscopically, and not to promote it here, don't get me wrong, but it's so much better outcome to the patient post-op on follow-up. I mean, again, I just wanted to add that. Thank you very much again. Go ahead, please.
Thank you. I'd like to talk for 2 seconds, the panel, about seromas after these operations, starting with Dr. Heniford and Chen. How does that relate into pain? I find that most seromas, which are pretty common, 10 or 15%, maybe higher, they don't usually hurt. Have you seen ones that do? And if so, do you treat them differently?
Go ahead, David.
Seromas definitely are pretty common. They typically don't cause a lot of symptoms. I think that when you have patients that come with a seroma and pain, it's usually unrelated. And a lot of times the seroma, you know, if you really are looking for it, you'll find them in an even greater proportion of patients. Very infrequently are they really clinically significant. So you really try and, usually the pain that you get that's accompanying a seroma is still in that early post-operative period. So I really don't see it as a predictor or a coexisting problem with chronic pain per se.
I certainly agree with that. When we've looked at a lot of patients over a long period of time, what corresponds more with chronic pain or even more acute pain out to a month or more is hematoma. Hematomas tend to cause a lot more discomfort long term.
Thank you. Dr. Ferzli, how do you manage your seromas that are large after a direct TEP? Can you hear me? I think we lost Ferzli's audio. Talking. I can't see him. Can everyone still hear me?
Yes.
Okay. Dr. Heniford and Chen, do you have any questions about my talk? If I could turn the mic back over to you.
I thought your talk was excellent, and we do much what you described. We actually go after the meshes that were implanted previously, removing the plugs and those sorts of things, because coming back, it's kind of the scorched earth phenomenon. Coming back is very difficult.
Exactly.
Yeah, I agree with you too. I think that, and laparoscopy really is an ideal way of treating the recurrence, because you really can see so much more, and you can see what went wrong. Even if you like to do open repairs and primarily for whatever reason, and when you really go back in and you repair somebody open, you sometimes see the pathology. But if you go in laparoscopically, you're guaranteed to see where the problem was. I agree with removing the meschoma. It definitely is. You don't want to go back into that scarred field. And that's really, when I do these triple neurectomies in the retroperitoneum, I really do it there because you're in a virgin plane. And so in those patients, if the meschoma pain is not a major contributor, sometimes I'll do the triple neurectomy and only go back for the meschoma if they complain about it afterwards. But otherwise, if you're going into the reoperative field, exactly, scorched earth policy, you take out all nerves, all mesh.
Absolutely.
And I agree with that. Dr. Ferzli, are you back online or no?
Yes, I can hear you very well, indeed.
Wonderful.
Hello? Yeah,
Go
can
ahead.
you? Yeah, I'm sorry. Go ahead, Brian. Go ahead, please.
No, we wanted to know how you manage a large seroma in a direct hernia space if it's causing pain, let's say after 2 months.
After 2 months, I will wait a little longer. I will try to wait a little longer. Then obviously I will do aspiration. But very rarely, I do, especially the scrotal, you will have a seroma. I do really a very big scrotal. And once you tell the patient, you may have to aspirate them, but you would rather wait as much as you can because sometimes they may just decrease in size.
Good. So we've reached the end. I want to ask my panel if they have any further comments they'd like to make. And of course,
one more thing. I'm impressed that you are going, Brian, after open preperitoneal and you're going laparoscopically. And it is as hard as step after step. Keep that in mind. So that is really good. I like that.
Well, I think it may be because I'm young and naive, but I do like the fact that it's a wonderful diagnostic tool, and you can learn a lot in this section what happened, and perhaps the repair is not best done at the end of that diagnostic procedure, but for sure it's a good way to start if you know how to do it and your patients can tolerate general anesthesia.
Excellent.
Certainly my preferred approach. I just want to thank Dr. Heniford, Dr. Ferzli, Dr. Chen for this amazing webinar. I really enjoyed this opportunity. I want to thank Dr. Matthews, who is online, for the opportunity to chair this. Certainly a privilege. And if there's no further questions, we'll wrap this up.
Thank you very much.
Thank you.
Yeah.
Thank you very much. Thank you.
Have a good night to everybody. See you all soon.
Thank you.
Bye.
Thank you.